People have been asking to do the ethics section because I kind of skipped over it the first time. So some people have their tests coming up, and et cetera, and everything else is done. So I wanted to just skip biochem for a little bit, wrap this entire section up. There's a lot to talk about in ethics. The first time around, I kind of skipped over it because I felt like a lot of it was just, reading it and understanding it yourself. But truth of the matter is, ethics questions can be very confusing. The answer choices can be very, like confusing mostly. You can see answer choices that will both make sense, right? Two answer choices. It happens every time you get an ethics question. You come down to two answer choices that both seem like the right answer choice, right? So there might be something like call the committee or say no, right? Take the gift or don't take the gift, some dumb shit. Give the blood transfusion only to this person and not that person, and so on and so on. And it's always very confusing to figure that out. Now, the point of ethics in America, in terms of the hospital patient, doctor-patient communication and relationship, is to make sure that we as doctors and hospitals, as an establishment and as a business, don't get sued and don't lose our um, no, yeah, I'm doing a video for ethics real quick right now, so not biochem right now. I will do more biochem later on, but I'm just gonna wrap up this ethics thing right now to get it out of the way. So the main goal with ethics is to, of course, yes, get the patient what they need, get the patient through with everything that they need help with, provide what they're going to be needing in terms of health and in terms of good advice, but at the same time also safeguard ourselves as a patient and not make a mistake where sorry ourselves as a doctor and make sure that we don't make a mistake where we're going to get sued and get the hospital sued and a bunch of lawsuits and stuff like that. So the core of ethical principles is, based off of these four words: autonomy, beneficence, non-maleficence, and justice. Right. So it just sounds very official using these words. It's great. Autonomy is the obligation to respect patients as individuals, to create conditions necessary for autonomous choice, and to honor their preference in accepting or not accepting medical care, right? So autonomy is a very special thing in America. They don't have this in many other countries where a patient can just choose to not accept medical care, right? Some patients, because of the condition they showed up with, it will be treated. Most times you won't even ask them if they want treatment for it. So that sense of autonomy is a special thing in America that patients use, right, all the time. Many patients out there, they don't want to treat their BPH, they don't want to get surgery for their cancer and rather just die, etc., etc. And you have to respect whatever decision the person wants for themselves. Now, respecting a patient as individuals, so truth telling and confidentiality, these two things get messed up so often, right? The reason we need this entire ethics thing in America is because there are doctors in America that are coming from all over the world, right? Many of you guys are medical students from many different countries. So when we are growing up and learning in our own country, there are different cultural things, there are different medical laws, there are different laws in general that we all grow up with. And because of mostly the cultural things and mostly also because of how the hospitals in different countries work, when we come to America, we have to learn that we can't do the same things that we've been doing in the hospitals back in our own country. Now, I've never done any medical schooling or any like rotations or anything like that in India, but I have experience of actually being in India and seeing, a lot of things that happen. And as an Indian, we all generally tend to know how hospitals in our countries work. And that kind of stuff just wouldn't roll here, right? So you can't go ahead and do something. And truth telling and confidentiality often gets messed up by doctors that come from other countries, right? So oftentimes doctors will not be able to sustain that confidentiality aspect of things. Like I've seen it many times where a doctor will go ahead and tell a patient, like tell the mother about things that happened with the daughter, right? And the daughter might be like 24, right? So she's her own grown-up adult, and you can't go ahead and talk about the daughter with the mother just because these guys all come to you and you're their family clinic. Right now, they're all coming individually, not as a family and sitting there together. You can't go ahead and talk about one patient to another patient. So that's definitely something you want to watch out for. You can't do the other way around either, right? You can't tell the daughter things that the mother needs. It just doesn't work like that. Right? So create conditions necessary for autonomous choice. So you got to make sure informed consent is there. That's the next topic. Right? So we'll talk about that when we get there. Second word is beneficence. Beneficence. Physicians have a special ethical or fiduciary duty to act in the patient's best interest. You got to act in the patient's best interest, not is what is in your best interest, not is what is on the hospital's best interest, regardless of whatever the hospital's rules might be, may conflict with autonomy or what is best for society, right? Traditionally, patient interest supersedes, right? Patient interest supersedes what is best for autonomy or what is best for society. So that's very important. Now, mandatory TB treatment, that's definitely something that you can't really do much about. You will almost never find a patient who doesn't want to get TB treatment, and if they don't, they're gonna die. You're not gonna let them out walking around spreading the TB, but they will end up just staying in the hospital and eventually die, right? So you have to treat the TB, and almost everyone will get their TB treated. But oftentimes, beneficiaries can have an issue with autonomy, right? So autonomy, you being able to make whatever decision you want to make as a patient versus what I think is best for you as a doctor, right? So those two things come into conflict, but at the end of the day, patient interest supersedes. So if I think something is better for you, but you want to do something else, and it's not the worst thing on earth, then you can do it. If I think a certain medication will help you so much more, but you want to take another medication because one of your friends is taking it and it's helping them and you like it, then I'm going to give you that medication, right? Unless there's some really serious side effect, really serious contraindication to why you can't take it, right? So that's definitely like a sample ethics question right there, right? You can easily get a question where that happens. You got to watch out for that, okay? So then it's non-maleficence. So mal, no doing bad, right? Do no harm must be balanced against beneficence. If the benefits outweigh the risks, a patient may make an informed decision to proceed. Most surgeries and medications fall into this category. All right, so every time a patient is about to get a surgery done, you're supposed to sit down with them. You're supposed to tell them everything that's going to happen during the surgery, what their alternative options are, right? What are the risks and benefits of this surgery? What can go wrong? What it's going to be like after the surgery? You got to tell the patient everything, and you cannot go ahead and do a surgery if a patient doesn't want it, right? So there's a lot of contradictions between non-maleficence and autonomy and beneficence. These guys do all clash heads, right? Autonomy will always clash heads with any of these other things because if a patient doesn't want something, even if it's going to keep them alive, the best thing for them, best thing for everyone else, etc., if they don't want it, they don't get it, and that's it, right? Last thing is justice. Treat persons fairly and equitably. This does not always imply equally, right? So like in triage, during triage, you always triage many other patients before the patients that have been waiting just because that person really needs to be seen in an emergency, right? So triaging is definitely one place where justice doesn't exactly, it's not that you go against justice, but just remember that justice is not treating everyone equally. It's treating everyone fairly and equitably, which basically is to say that you can't mistreat someone because they're poor. You can't mistreat someone because of the skin of their color. Sorry, the color of their skin. You can't mistreat someone because of the religion they follow. You can't mistreat someone because of the sexual orientation they follow, and so on, right? All of that you have to turn a blind eye to, but you do have to know. You should know. You should know the religion a person follows, right? Because that can impact whether or not you give them blood transfusions. You need to know the sexual orientation someone follows, because if they are a man who is having sex with a man or a woman who's having sex with a woman and so on, that really can affect how you treat someone because of the medications that they're supposed to be given, right? Or because the differential diagnoses that you can actually cancel out. All right, so there's a lot of things that you have to know everything, but it's not supposed to affect how you treat them in the hospital. All right, so next thing, informed consent, right? And that came from the autonomy aspect of things, right? So a process, not just a document or signature, right? A signature alone doesn't do it. Now, as we've all seen in many movies from our countries, and definitely in Indian movies, I've seen it all the time, a signature is more than enough for informed consent. That's not how that works, right? So it's a process, and these bullet points kind of pointed out. Disclosure, so discussion of pertinent information, and you have to use a medical interpreter if necessary, right? It's not enough for me to try to show you or tell you and hope that you understood. No, if you speak a different language, I will call an interpreter service and make sure they tell you everything in your own language, right? Many things mean different things in different languages, and people think they understood what you said, but they actually understood something else, right? So disclosure, discussion of all pertinent information, understanding, right? They have to understand, which again goes with the medical interpreter aspect of things. Like if they didn't understand, how would you know? Like, you have to ask them to repeat, okay, so tell me what you understood. And it's not that easy to repeat entire medical procedures and risks and benefits. So you have to make sure they understood the first time you were telling it to them. Capacity, ability to reason and make one's own decision, right? And that's different from competence, which is a legal determination. Competence, whether or not you're competent to make your own decisions, comes from like age, and basically just age for the most part, how old you are. Whereas capacity is all about like, are you entirely drunk? Because then informed consent won't work, right? Are you someone who has any kind of mental illness? Then you don't have the capacity to make your own reasonable decisions, right? If you're really, really, really hurt by something, or maybe you're just going crazy because someone died, there's no way you can give informed consent. You have to be mentally stable to be able to reason and make a good decision. The last thing is voluntariness, right? Freedom from coercion and manipulation. A patient should only be wanting to do something because they want to do it, not because someone blackmailed into doing it, someone, threatened them to get it done. None of that is going to work, right? And where does that happen? So that can happen in situations where you have something like a woman getting a hysterectomy, right? Many times it happens that men force their wife to get a hysterectomy so they don't have to worry about using a condom and etc., etc. But some women don't want to get a hysterectomy, and if they don't want to get a hysterectomy, you can't do anything about it, right? So if a woman comes in and she's signing all this, disclosure and all this stuff, she's signing documents and understanding the informed consent aspect of getting a hysterectomy, you have to make sure that she doesn't look like she doesn't want to get it done, right? And that's entirely subjective, right? It's going to be up to your judgment to be able to catch that. So that would be a pretty good question. That would be a pretty good example of somewhere informed consent can be messed up because of coercion, right, and manipulation. It doesn't happen in many places. There aren't many surgeries out there that you can think of for that kind of example. Patients must have an intelligent understanding of their diagnosis and the risks and benefits of proposed treatment and alternative options, including no treatment, right? If this is an option, you have to tell them that. You have to tell your patient, hey, look, we can do X, Y, and Z. We can also do A, B, and C, but we can also just do nothing, and you're not going to die. Right? So they need to know that. You don't go ahead and withhold the no treatment aspect of things because it might make you more money to get the surgery done, right? Very common thing in India, very common thing in many other countries. You don't go ahead and tell them to, you don't withhold the no treatment option simply because you think that you'll look better because you told them something and it helped them. Right? But if they didn't want to get it done, they're not going to want to get it done. End of discussion, right? Patient must be informed that he or she can revoke written consent at any time, even orally. You have to let a patient know that they're not being forced to make this informed consent. They don't have to. In fact, they can orally say, I don't want any of this to be done, and that's it. It's done. She doesn't have to sign anything, he doesn't have to sign anything anymore. It's done. You can revoke consent anytime, even orally. But that anytime comes with making sure that you are of capacity, all right, that you're not being forced. All of these things are always going to count. Now, exceptions to informed consent go with this wipe thing, right? So wipe it away. The waiver is a given. It's very obvious, right? If you have a waiver, then the patient has explicitly waived the right of informed consent. They don't want informed consent. So just do whatever you need to do to me and just get it done with. You don't have to ask me for permission. If they gave you such a waiver, you go ahead and do every procedure you got to do and just get it done, right? Then there's legally incompetent, right? Competence is different from the capacity thing. So this is where a patient lacks decision-making capacity and you have to obtain consent from legal surrogate. But this capacity is different from the other capacity. The capacity over here is about mental capacity, right? Is this person in the right state of mind to reason? Whereas here, the competence thing, this capacity is, are you old enough to know what's right for you, right? If you're a 14-year-old, 13-year-old, and you want to make a decision about getting an abortion, that is a very common type of question, right? And we're going to get into that. But informed consent, if you're legally incompetent, then it doesn't matter. You don't need informed consent. Whatever is right for you will be done, right? Then there's therapeutic privilege. This one gets tested quite often too. Withholding information when disclosure would severely harm the patient or undermine informed decision-making capacity, right? So I'm going to not tell my patient something because I feel like if I do tell it to them, They might even get a heart attack and die. Or if I do tell it to them, they're going to lose their mind and not be able to make the right decision. Right? So that's therapeutic privilege. It's not anything else. It's therapeutic. I'm only holding it back because I know for sure that it's not going to harm them. And this is such a touchy topic, right? Because I might feel like I know that I shouldn't tell my patient this information and that it'll be helpful to them, but will it really? Right? And it's a really hard way to judge that. But there are many examples of therapeutic privilege, and one of the common ones is, do you tell a patient that they have cancer when they're 75 and it looks like they might just die like in a couple years anyway because they have other comorbidities, right? So telling them that they have cancer at that exact point wouldn't really do much. But at the same time, like, would you really withhold it? Because if you tell it to them, well, they're already old enough, they'll probably understand, and it wouldn't really do much. It won't do anything. Then there's young women, right? Young women, telling a young woman that she has stage 4 endometrial cancer and she's about to die. Right? That can be really, really scary. So the question when you're reading it, right? Now, all of these examples I gave, they're pretty much examples where you wouldn't withhold the information. Like, you have to tell it to them, even though it looks like a scary thing. But if you get a question on therapeutic privilege, the question will lead you in such a way that in your mind you should be able to think, okay, I see what this guy's trying to do. The question writer wants me to withhold the information, right? Because if I tell it to the patient, it's going to end up harming them. All right. Last thing is the emergency situation. Implied consent may apply if it's an emergency situation, right? If a patient is so injured, maybe in a car accident or something, and they really can't do anything about it, they can't say anything to you, you don't need their consent anymore because you got to save their life, right? They're not in any position to give you consent. Maybe they're not even aware of what's happening to them. Maybe they're not even conscious, okay? Last thing on this page is consent for minors. Now, a minor is generally any person under 18, right? This is like the general law in America. If you're under 18, you're a minor. Once you're 18, you're not a minor anymore, but you're still not an adult. Parental consent laws in relation to healthcare vary by state, which kind of sucks, right? So every state has its own law about consent for minors. In general, parental consent should be obtained, but exceptions exist for emergency treatment like blood transfusions, or if the minor is legally emancipated, right? So you could have a 16, 17-year-old who is no longer a minor because they're married, or they're self-supporting, or they're in the military, right? If you're in the military, then you no longer count to be a minor, even if you're 17 or 16, because now you are legally emancipated. And the blood transfusion thing, now, you have to ask for permission where you can, but if you can't ask for permission, you just go ahead and do it. You don't need to get consent, right? So if there's a little girl and she's 16 and she's dying and she's lost a lot of blood and you need to give her a blood transfusion, you can ask her parents. But if they're not there, if they're not responding, and she's knocked out herself, you just go ahead and do the blood transfusion. That's it. There's nothing else about that. Situations in which parental consent is usually not required. Sex, right? So for contraception, STIs, and pregnancy. Parental consent is usually not required for sex things, drugs things, so substance abuse, and rock and roll. This is supposed to be for emergency and trauma, right? Sex, drugs, and rock and roll was actually a theme once in a time at the hippie period in America, where this is what everyone was doing, right? So everyone was just having sex with everyone. They were just nonstop doing drugs, and there was a lot of rock and roll in that time period in America. So this is what they're using here to help you remember that these exact topics do not require parental consent, right? So pregnancy, STIs, contraception. Now keep in mind it says pregnancy and it doesn't say abortion, right? It does not say abortion. It says pregnancy does not require parental consent. So if a girl is pregnant and she wants to stay pregnant, that doesn't require parental consent. She can stay pregnant. Abortions, however, are a different thing, and we're going to get there. Physicians should always encourage healthy minor-guardian communication. So this word always, right? You're going to get answer choices where it's going to be like tell the parents to talk to the child, or tell the minor to talk to her parents. Have them communicate. That is the right answer. That's always the correct answer. If in your question stem it hasn't happened so far and there's nothing in the question stem that tells you that communication is not going to go well whatsoever, you have to tell them, you have to encourage it. Have healthy conversation. Let's go talk. You guys need to talk to each other, right? Physicians should seek a minor's assent even if their consent is not required, right? Seek a minor's assent even if their consent is not required. So if their consent is not required, it's still important to search for this thing. Now, if you don't know what assent is, right, there's a lot of people that don't know what assent is. So you go ahead and Google that, and on Google it says it's the expression of approval or agreement, which it makes sense, right? That's the only thing this could have possibly meant. So physicians should make sure that a minor is still okay with what's about to happen with them. Asking, hey, I'm going to do this to you, is that all right with you, is different from, do I have your permission to do this to you, right? The second thing I asked is consent. The first one is me just making sure they're going to be okay with me doing it. If they say no, it's still not going to really stop anything because I'm not asking for permission, but I'm being respectful. I'm making sure you know what's about to happen. I'm hoping that you're going to agree with what we all think is the best thing to do. But the minor thing can be such a problem, right? And then there's decision-making capacity. So that one was the capacity thing right here, right? So this is still under informed consent, which is still under autonomy, right? So decision-making capacity. Physician must determine whether the patient is psychologically and legally capable of making a particular healthcare decision. Note that decisions made with capacity cannot be revoked simply if the patient later loses capacity, right? So if I'm completely sane right now and I make a decision about something I want to do, and then later on something happens to me and I'm like, yo, I don't want to get that done anymore, too bad, right? Because now something happened to me and I'm not in the right mental capacity, I'm not in the right mental state, I'm not thinking about things correctly, and that's a tough place to be in. That's a tough place to be in. You got to make sure that, you know, you're going to get a question on this, right? You're going to get a question. A patient came in, might be like an 80-year-old patient, and the patient goes ahead and says like, oh, yeah, I want to get the colon surgery done, right? And then later on they might have like a weird moment and they get seizures, and then they have like some kind of depressive moment, and now they're just not talking correctly to you, and now they're trying to say, oh, I don't want to get this colon cancer removed anymore. You still go ahead and remove the colon cancer because you're going to base it off of how mentally stable they are. It's not going to sound like that they're that mentally stable. And if it doesn't sound like they're that mentally stable, it's not okay. All right? So that's definitely something you want to watch out for. So that's what they're saying. All right? Decisions made with capacity cannot be revoked simply because you lost capacity after you already made the decision. Capacity is determined by a physician for a specific healthcare-related decision. Right? So, for example, to refuse medical care. Competency, the comparison they were making earlier, is determined by a judge and usually refers to more global categories of decision making, like legally unable to make any healthcare related decision. Right? So capacity is only used for one very specific thing. Like if a person is refusing medical care and they tell you, I don't want to get anything done for myself, well, now you have to check, are they depressed? Are they saying that because they're depressed and they just want to die? Are they saying that because they're really emotionally unstable right now and they don't care about their life because they just lost their girlfriend? Right? You got to make sure all these things are not the problem, and that they're saying they don't want any treatment because they really don't want any treatment, and that's it. Right? Even if they're going to die without the treatment, they say they don't want it, and they're completely normal, they have mental capacity, and they're completely aware of what they're saying, then you go with that. Now, they have this GEMSA thing, right, which is a stain in microbiology, right? So GEMSA staining. Components think GEMSA. So goals, informed, express, mental status, stability, and age. Decision is consistent with the patient's values and goals. If a patient has never mentioned something about some kind of decision they're making now, and then all of a sudden they're making a decision, it's probably not them talking. Patient is informed, knows, and understands what they're saying. Right, if they're talking about something without really knowing what's happening or knowing all the details, they're not informed. Patient expresses a choice. This expression thing is big, right? Stating a choice is different. If I just state a choice, it could be because someone told me to, something else influenced me to. But if I express it, if I really show like, hey man, you know what, like I'm alright with this. I don't want to get anything done, and that's it. Then I'm expressing it. I'm literally like, it's coming from my heart, it's coming from my own mind. Decision is not a result of altered mental status. So you got to make sure your patient isn't delirious, isn't undergoing any form of psychosis, and is not intoxicated, which doesn't just mean alcohol, but it can also mean anything else, like weed, any of those other drugs like PCP, LSD, etc. All right, so you really got to make sure that they're not having anything that would go ahead and make their mental status or their mood to not be what it normally should be, right? Abnormal. And that's a tough one, right? That's a really tough one. You can get a completely normal looking patient, but they might be like 85, 86. Then you want to assume, like, there might be some level of delirium here, and they might have done something in the hospital which was really delirious, like maybe fighting with a nurse for no reason. Now this patient is not of mental status where they can make decision. They don't have decision-making capacity anymore. Decision remains stable over time. So that's something that happens in the hospital all the time. You meet a patient for the first time, you tell them everything, you did all the risks and benefits and all that, right? You told them everything that's going to happen, alternates and all that, and then they tell you their decision. Great. Now later on, throughout the multiple times you're going to see this patient, you keep asking them. So this is what you want to do, right? Okay, so we're going to do X, Y, and Z. That's how you want it, right? You keep stating it, but you don't keep asking the same question over and over, because that's just going to become angering, and it can sound a little weird, like, what, should I not be getting this done? Are you sounding confused, or are you just making sure I'm trying to get this done? So decision has to remain stable though. If the patient seems iffy, right? If the patient seems confused, if the patient seems scared and doesn't want to really get it done, or they look like they're scared because someone's forcing them to get it done, like that example of a hysterectomy I gave earlier, then it's not a stable decision and they don't have decision making capacity. The last thing is patient is over 18. Right, over 18 or legally emancipated, which means being married, self-sufficient, or being in the military, anything that shows that they don't really need any kind of adult guidance or care, then patient is basically of age. So decision-making capacity, really tough stuff. It looks really obvious. It looks like it's going to be common sense things, and then you get a question, and that's where it starts becoming a little difficult. The latter half of this page is about advanced directives and surrogate decision-making. Now, the surrogate decision-making thing is not that bad. I've seen questions on surrogate decision-making stuff a lot of times, but the advanced directives can definitely be difficult. The easiest one, in my opinion, is the DNR, right? So a DNR order prohibits cardiopulmonary resuscitation. Other resuscitative measures that may follow are also typically avoided, right? So if a patient has a DNR, then no matter what, right, if the patient is no longer of mental capacity and then all of a sudden this patient is about to die, you do not go give them CPR, you do not give them a feeding tube, you don't attach them to a machine, you let that person die. Because that's what that person wants, right? Many people do not want to go through the harassment of, CPR and a feeding tube and all the machinery and then attaching a urinating tube and keeping someone alive if they have a DNR, right? So for example, I will probably also get a DNR later on for specific things. Like if I'm ever comatose and I'm not moving and I'm injured and the chances of me coming out of this coma thing is very, very unlikely, I will have this DNR make sure that I'm not sustained in this way, right? Not just for myself, but also because I don't want my family or anyone I have there to be seeing me like that. So there's a lot of things involved. Remember, ethics falls apart the moment you start thinking of things in your own perspective, right? It's not about you, it's about the patient, right? Just because the patient wants to make a decision and you don't think it's the best decision, that doesn't mean shit, right? It's the patient's life, it's what the patient wants. You have to go with whatever they think is best, right? So as a patient, if I don't want to be resuscitated when I'm in a coma, then that's it. You're not going to go ahead and keep me alive anyway and hope that things work out just because everyone around me is like, no, keep him alive, keep him alive. No, they're just being emotional. I don't want them to see me like this anymore. End it. And that's it, right? So that's what DNR is all about. An oral advance directive, OAD. Incapacitated patients' prior oral statements commonly used as guide. Problems arise from variance in interpretation. If patient was informed, directive was specific, patient made a choice, and decision was repeated over time to multiple people, then the oral directive is more valid. So this is why oftentimes what happens, right, is you get consults. So in a hospital, a patient comes in and they have certain comorbidities. Maybe they have a heart problem, they have a lung problem, they might even have a GI problem, right? So now what I'm going to do is I'm going to call in the cardiologist at the hospital for a consult, the gastroenterologist at the hospital for a consult, and they're all going to come in, they're all going to talk to this patient, they're all going to understand how this patient thinks, what this patient wants, right? And then they're all going to go back to their computers and they're going to write their note. I spoke with this patient, he wants this and that, he speaks like this is what he sounds like, he seems fine, right? Later on, if there's any problem and this patient becomes incapacitated, we can go to all of these doctors' notes and see what does this patient look like in terms of their mental decisions. What do they want for themselves? Do they want to keep being alive? Do they want to be taken care of and kept alive and fixed? Or do they want to not do anything? Right? And then that would count as an oral advance directive. What this patient said about the decisions they want to make to multiple doctors will be the perfect oral advance directive. Cedric is asking what happens if the patient has a DNR, but they told a nurse that they wanted to live. In that case, how do you approach it? So that's a very difficult case right there, right? You have a DNR. If you have a DNR and now you start talking about you want to live, it doesn't count, right? But there's a lot to look at. Like it's one of the things that I always found really annoying about many other topics as a math major is that in math, 1 plus 1 is always going to be 2, and there's always proof for it, and there's always solidity to it. There's no other things involved. In anything else, though, there are other things involved. So here, the patient, if it's a really old patient, right, and maybe something happened, maybe the patient finally saw his great-granddaughter for the first time, right, and now he's like, you know what, I want to live. Too bad. Like, it's not going to work. The DNR already says you don't want to be resuscitated, and maybe a couple of days ago you told a nurse that you want to live, and now today this patient is unconscious and he's about to die. That patient will end up having to die, right? Just one nurse coming up and telling everyone, oh, he was telling me yesterday that he wants to live, it's not really going to be enough. It's not really going to be enough. Maybe the nurse and this patient became close, and the nurse just, feels bad that he's about to die. It's so complicated, right? It's so complicated. There's so many things involved. And you also have to look at the comorbidities of this patient. If this patient wouldn't really live after the DNR anyway, there's that. The worst thing about it is that if you go against the DNR, right, because you feel like you're helping a patient or you're doing something that the patient wanted, you could end up losing your own license, right, because you went against the DNR. So now you're out here weighing, okay, this person's life or my life's entire work, right? Because now I'm going to lose my license and I'm not going to be a doctor anymore. So there has to be very solid stuff there. So telling a nurse that he wants to live isn't enough. But if you told a nurse, if you told his doctor that, hey, I know I have a DNR out there, but I want to revoke that DNR now, then he's good, right? Now, if he's ever needing CPR, we're going to give him CPR. All right, so that's all the stuff you want to watch out for. Put yourself in those shoes and stand there with this patient in this mode, right? With this nurse coming in and telling you, and we love nurses, right? We love nurses in America because they're the ones that actually take care of the patients. They're the ones that are there with the patient, feeding them, giving them medications, cleaning them, making sure they're doing everything okay, making sure they're urinating right, pooping as many times as they need to, right? Because we have to count how many bowel movements they had, to watch out how the medications are affecting them. You have to check, if they're getting the right food, all of these things. Nurses are extremely critical, but a nurse can't just come up when this patient is knocked out, unconscious, and come and tell me that he wanted to live. Like, I'm sure he did, but his DNR says otherwise, so he has to die. And that's it, right? That's as simple as that gets. But a patient can revoke his own DNR, but they have to tell you that. They have to tell you, like, I think I'm about to pass out and I might not make it tomorrow. That surgery might actually end up killing me or putting me into a coma. I want to let you know that I have a DNR and I want to revoke it. So now as a doctor, I know that you verbally told me you want to revoke your DNR. I'm going to write that down into my notes. And when you ever need CPR, I'm going to give you CPR. Right? And I'm not going to lose my life work because I wrote it in my notes that you told me you want to live. I'll even have other people around, right? Nurses are going to be there. Everyone's going to be there as a witness. So you want to make sure you get that correctly, all right? And we just talked about oral advance directive. Next thing is a written advance directive. So that's even better than the oral one, right? Specifies specific healthcare interventions that a patient anticipates he or she would accept or reject during treatment for a critical or life-threatening illness. A living will is an example of a written advance directive, right? And very few things can overcome a written advance directive. But if a patient orally says that I don't want to go with what's in my written advance directive, just like they could say I don't want to go with my DNR anymore, then that overcomes it. But we're assuming that the patient is no longer in capacity, right? At the top it says instructions given by a patient in anticipation of the need for a medical decision. Details vary per state law, which is not that big of a deal, but we're assuming in this position right now, we're assuming that the patient can't talk to you anymore. The patient can no longer talk to you anymore. So now that they can't talk anymore, we look at their written advance directive, and whatever it says there, we check if they have a DNR. And if everyone agrees in this little meeting we're all going to have with the nurses and all the doctors that ever tended to this patient, everyone agrees what needs to be done, then you go ahead and do it, right? Hospitals have meetings all the time. There will be meetings with multiple doctors coming because these are all doctors that at some point worked with this patient. And now this patient needs to get a big decision made, so everyone comes together to help make that decision. Last thing here that we didn't touch is medical power of attorney. So everyone has an idea of how a power of attorney works. Patient designates an agent to make medical decisions in the event that he or she loses decision-making capacity. Patient may also specify decisions in clinical situations can be revoked by patient if decision-making capacity is intact. More flexible than a living will. Right? So a medical power of attorney is different compared to a written advance directive because a written will, you've written X, Y, and Z is what you want. Now that can't change anymore, right? So if something's happening to you, we're going to look at your will and be like, all right, well, he chose X, Y, and Z, so we'll go with X, Y, and Z. Whereas a medical power of attorney is someone who really loves and cares about you, someone that doesn't hate you, obviously, right? And this person is flexible. They can make decisions for you based off of what a doctor is telling them, what others are suggesting is the best case scenario, right? What they understand about you and what they know about you personally. Using all of that, they can choose a different decision for you compared to, a written advance directive can't really choose a different decision for you, nor does a written advance directive listen to a doctor. It's already written. It's literally written in stone, right? So it's going to happen. Now, the final thing on this page is a surrogate decision maker. If a patient loses decision-making capacity and has not prepared an advance directive, then individuals, any surrogate, right, that's the surrogate, individuals who know the patient must determine what the patient would have done. Now, priority, who does priority go to? So if I use myself as an example, then, assuming I'm married, my wife would have the next level of making decisions for myself. If my wife is gone, then my kids have the next level of making a decision for me, right? This is so non-Indian, right? In an Indian mentality of things, it all comes down to parents, right? Whatever decision you need to make, then it doesn't matter who you are, what you do. Maybe it matters if you became a doctor right now, but that's a whole different thing. Other than that, nothing matters because if you don't have mental capacity, the only person that they would think is parents, and that's wrong, right? So it's a spouse, your wife or your husband gets to make a decision for you, and then if your husband or wife isn't there because you're divorced, or your husband and wife, whoever it is, let's just stick to wife since I'm talking. So if my wife is someone that I have a very bad relationship with, then she won't really count, right? Because this is someone that, although it is my spouse, they can't come and talk for me because if they hate me, they'll probably make a bad decision for me, right? So after that, it comes down to children and then parents, right? Maybe I don't have kids either, or my kids have, they're out of reach, they're too far or something like that. Then my parents, if they're around, they're gonna make the decision, and then it comes to my siblings, right? So my siblings are the last thing here. And spouse chips is a pretty nice way to remember that. Spouse chips works, right? Spouse and then CHI for children, the P for parents, and the S for sibling. I never had an issue trying to memorize this. And if you get a question on a surrogate decision maker, it's usually a very straightforward thing. You just pick the right person because you remember spouse chips and you're done. Right? If they try to complicate it with things, then it'll be like how I described it, where the wife and husband are constantly fighting and they hate each other. Then do you still go to the spouse or not, right? So you got to watch out for that. And that's generally all there is to that. Now, this is the meat of ethical questions, right? This is the stuff that many people are confused about. This is, I'm pretty sure, the part that the people that asked me to do this video before I keep moving on with the biochem redo videos need help with. So let's just run through these guys. In the next video, I'm going to go through all of these one by one, talk about them very specifically, and make sure that it covers everything you need to know. So I'm going to end it right now, and then I'll come back in a little bit after eating and go through the rest of these ethical situations and how to deal with them. Thanks a lot for joining, and I'll see you guys really soon. Oh, wait. Carla. Hey, I'm here. Thank you for doing this. video. I'm reading hematology with you now. All right, cool. Yeah, I'm glad I could help you guys. So keep it up, and best of luck, everyone. I'll be right back, and we'll go into the rest of these ethical situations.